Now, Professor Hazem elhayroti, he will talk about false lumen embolization in aortic dissection, a comprehensive analysis.
So, thank you, dear chairpersons, dear colleagues. I would like to talk about false lumen embolization by aortic dissection, my disclosure. So, aneurysmal degeneration occurs in 40% of patients after TVAR by aortic dissection. And aneurysmal degeneration occurs, as I said, 40% by TVAR by aortic dissection. Patency of false lumen and aortic diameters are predictors and outcome in type B by aortic dissection. Why? Because a patent false lumen can lead to aortic dilatation, which in turn increases the mortality during the chronic phase of the disease. In addition, complete thrombosis of the false lumen can lead to positive aortic remodeling, improving clinical outcomes. What we mean about positive aortic remodeling? So, according to the classification, we distinguish positive and negative aortic remodeling. Definition of aortic remodeling actually varies among lots of studies, some authors describing it as true lumen re-expansion and false lumen thrombosis or false lumen shrinkage with or without stable diameter of the total aorta. So I decide to ask ChatGPT about the meaning of aortic remodeling. And the answer was returns to a more normal size and function improving hemodynamics. That means ChatGPT mentioned here the anatomical and the hemodynamical variables together, which is very important. A study by Mani showed that patients who underwent aortic remodeling have a better life expectancy than those who did not. Another paper by Tsai showed that patients with partial false lumen thrombosis have increasing of 3 years mortality more than patients with totally true lumen thrombosis, 30 versus 20%, as you can see. In 2020, the Society of Vascular Surgery and the Society of Thoracic Surgeon published a report on type B aortic dissection where the term type R entry flow was introduced to describe the flow in the false lumen. The first paper actually on false lumen occlusion was published 2003 by Luber from Netherlands with collaboration with the radiologist. He introduced the concept of the cork in the bottle neck. In this report, they publish about, or they record about 2 cases were described. In the first case was implanted 2 Greenfield's filters, 6 detachables balloon, and 5 thrombine were used in the abdominal aorta to occlude a false lumen and surprisingly above the left renal artery. In the second case, a 24 millimeter talent occluder was implanted in the mid of thoracic aorta. 10 years later, Professor Kolber from Germany introduced the same concept or similar concept under the name of candy plaque technique. This was an innovative homemade modification of the Zenith thoracic stent graft, which has successfully implanted in the mid-descending aorta. 4 years later, the same group published the first study on the custom-made candy plaque in 18 patients. And you can see here, we have a follow-up period of 9 months, remodeling by only 7 patients. So I would like to present here a first case of my patients. This is a multimorbid patient who underwent aortic ascendance by aortic dissection. In follow-up period, the CT revealed a dilatation of aortic arch and thoracic aortic aorta. So we decide to perform frozen elephant trunk. It means replacement of arch and descending aorta. The operation was done perfectly. And after 4 hours on the intensive care, the patient was unstable. We performed a CT, emergent CT, and as you can see here, false lumen ruptured with true lumen collapse. So I took the patient directly in the operation room, and as you can see here, I performed distalization of this TEVAR with 250 millimeter TEVAR until the celiac trunk. As you can see here, the deployment of the stents. So after ballooning of the TEVAR, as you can see here, the DSA showed a further perfusion of the ruptured false lumen, which we call type R entry flow. So what should I do? Therefore, we decided to complete the treatment by candy plaque as emergency also simultaneously. That was the implanted candy plaque, about 100 millimeter length, 38 millimeter diameter, with a tunnel in the middle, 25 millimeter length, and 60 millimeter diameter. After the cannulation of the celiac trunk to prevent any kind of complications such as occlusion or migration of the candy plaque, as you can see, after cannulation, I put a rosin wire in the celiac trunk. And after that, I advanced advantage wire as far as I can in the thoracic aorta. And as you can see here in the third video, so I implanted a candy plaque 1 centimeter above the celiac trunk, and then completed this maneuver by implanting implantar occluder plaque with a 22 millimeter. This was the intraoperative DSA and the postoperative 3D rendering aorta, and as you can see, totally occluded false lumen. So this is my results in minds. This kind of occlusion was performed by 12 patients, but was 13 operations. Why? I will show later. So as you can see, 90% of patients were male with multimorbid, and 80% of these patients had a history of type E aortic dissection with aorta ascendance replacement. The average operation time was 220 minutes. Fluoroscopy time was 30 minutes. The average of hospital stay was 8 days. Must CP from Terumo, and the must implantar was 22 millimeter. There was no aortic related mortality during a median follow-up for 30 months, but the late mortality was about 23%. Here, after 3 years, we can observe good remodeling with an expansion of the true lumen, as you can see here, significantly also, and shrinkage of the false lumen. And this was why I performed 13 operations by 12 patients, because here I can show you a case where I had implanted second candy plaque in follow-up period by patients who underwent also twice false lumen perfusion by aortic dissection. And to my knowledge, this is the first patient worldwide who had a double candy plaque. So, to conclusion, false lumen occlusion lead to positive aortic remodeling. However, long-term follow-up data is essential for these patients. Thank you.